Can you see, can everyone see Jenny's presentation?
Yes.
Okay, great. I'll
So
just,
good morning, everyone. We're just going to get started on today's grand rounds, which are the last grand rounds of our academic cycle. And as is tradition, the PGY5s will be providing a recap of last week's Walter Wright meeting. I do want to congratulate our co-chairs, Dr. Sundram and Dr. Najawan, as well as the entire planning committee led by Dr. Alan Slomovic on just another wonderful Walter Wright meeting. The feedback I've received and the feedback they've received seems to be universally positive, and I think that speaks to the hard work that this planning committee put in all year. So congratulations to Dr. Sundram, Dr. Najawan, Dr. Slomovic on a wonderful meeting, and I look forward to the update this morning from our PGY5 residents.
Hi, good morning, everyone. Can you see my slides?
Yes.
Perfect. So I'll be starting off our summary of Walter Wright. Similar to what Dr. Wright said, it was an amazing learning experience and a great review for us, both in terms of neuro-ophthalmology and oculoplastics. I'll be reviewing session 1, titled Combined Neuroplastics, How to Manage Challenging Inflammatory Disorders. It was moderated by Dr. Lam, and our panelists were Dr. Najawan and Dr. Mason. So our first talk was given by Dr. Prasad from the University of Pennsylvania, and it's titled Unusual Manifestations of Cavernous Sinus Disorders. Just for the sake of time, I've outlined quite a few learning pearls from each talk, but we'll highlight one specific pearl that I think we can all kind of take away from that talk. So for Dr. Prasad's presentation, the pearl is really to consider the diagnosis of ocular neuromyotonia in patients who present with diplopia with a history of radiation of a paracellular lesion. So ocular neuromyotonia is effectively delayed relaxation of an extraocular muscle that makes the eye feel temporarily stuck, so to speak, after eccentric gaze. So a patient with an atypical history of diplopia, with a history of radiation of a paracellular lesion, for those instances, consider ocular neuromyotonia. Dr. Nasrallah gave a fantastic talk titled Orbital Cellulitis, Approach and Management. And for his talk, a great pearl is for older patients with poorly controlled diabetes or who are otherwise immunocompromised to consider the diagnosis of mucormycosis. And in considering this diagnosis, performing a thorough head and neck examination with a specific emphasis on assessing for an eschar. Dr. Fraser gave a fantastic talk titled Orbital Inflammatory Syndrome and Tolosa-Hunt Syndrome. And he provided us with a wonderful overview of a variety of different etiologies that could present with OIS. But the main takeaway for his talk was really to think twice before giving a patient a diagnosis of Tolosa-Hunt syndrome, and rather diagnosing idiopathic orbital inflammatory syndrome instead of Tolosa-Hunt, given that there are a lot of underlying etiologies that can present with OIS, and many conditions that are newly discovered and things that have not yet been identified. Dr. Najawan gave a thorough assessment of an approach to diagnosing thyroid eye disease. In his talk, 2 pearls to consider. First, an anatomic consideration. It is 7 extraocular muscles, not 6, that are involved in thyroid eye disease, so not forgetting the involvement of the levator. And also considering the importance of smoking cessation and counseling around smoking cessation, as it is the strongest modifiable risk factor for progression of thyroid eye disease. Our very own Dr. El-Nadi, PGY4, gave a great talk titled Epiphora Nasolacrimal Duct Obstruction and Dacryocystitis. And his talk really highlighted the importance of considering functional epiphora in patients who are being worked up for NLDO. In patients with functional epiphora, the lacrimal system is anatomically intact and normal, but functionally insufficient. And when considering this, recognizing that syringing is not sufficient to diagnose functional epiphora. Dr. Sharma gave a great talk titled Cavernous Sinus Thrombosis and really emphasized the potential morbidity and mortality associated with this diagnosis, which further emphasizes the importance of diagnosing this early and treating it early. I'll also give a brief overview of a few talks given on Saturday, session 5, titled Orbital Disease and Malignancies. Our moderator was Dr. Nijawan, and our panelists were Dr. Jeremy Goldfarb and Ryan Mason, Doctors Jeremy Goldfarb and Ryan Mason. Our first talk was from Dr. Wiladis, and he gave a fantastic overview of medical and surgical approaches to managing thyroid eye disease. Specifically, he talked about the role of selenium in patients with thyroid eye disease. Selenium is known to decrease free radicals, suppress pro-inflammatory prostaglandins, regulate B cell function, and control cell-mediated immunity. And its utility in patients with thyroid eye disease is supported by the UGOGO trial. However, he highlights the fact that selenium is proven to be beneficial in environments that are selenium deficient, namely in Europe. In North America, where selenium deficiency is less prevalent, its utility may be more limited. And lastly, the Jeff Hurwitz named lecture given by Dr. Kahana, titled Targeted Medical Therapy for Thyroid Eye Disease, Mixing the Old with the New, was a great overview of the pathogenesis of thyroid eye disease and opportunities for new therapies. He specifically emphasized that understanding the molecular underpinnings of thyroid eye disease and the immune dysfunction that triggers this condition leads to improved treatment options for patients. And teprotumumab really highlights that principle very well, as does vitamin D supplementation. And that's it for me.
Okay, well, thank you, Sonia, and we'll move on to Prem.
Hi, everyone. I'm Prem. I'm a PGY5 as well, and Walter Wright was great, as we all know. These are a couple quick summaries on session 2, and then one summary for a presentation in section 5. So starting with Dr. Synderum's approach to a swollen disc, he simplified this daunting topic into 3 dichotomies: unilateral versus bilateral.
Do you want to just go to presentation mode?
Oh, sorry.
Sorry.
Just is that working now?
Perfect. Thank you.
Okay, perfect. So he simplified the topic into 3 dichotomies: unilateral versus bilateral, painless versus painful, and vision loss versus normal vision. And if you have a bilateral swollen disc with normal vision, your main battle is distinguishing between papilledema and pseudopapilledema. Dr. Synderum's pearls for pseudopapilledema include looking for a crowded disc with visible spontaneous venous pulsations. And crucially, in pseudopapilledema, the vessels stay visible as they cross the margin. They aren't obscured or buried like in true edema. And generally, you won't see hemorrhages or cotton wool spots. If you see those, it's real. Moving on to the next presentation, Dr. Mullen's update on IAH. The major takeaway is a paradigm shift. Essentially, one thing that she was mentioning was we need to stop treating IAH just as a plumbing problem and start treating it as a systemic metabolic disease. She highlighted that weight loss is the only true disease modifying treatment, but there is data that's showing while stenting and shunting are potential options, there are downsides and upsides to each one. And she also stratified treatment based on the type of vision loss or the amount of vision loss based on visual fields. So less than -2 decibel mean deviation versus, or greater than, and then less than a -7 decibel mean deviation, which would indicate surgical territory. And finally, there are some studies like the dual trial that are suggesting the potential impact of GLP-1 receptor agonists. Sorry, the next slide here is the Dr. Graham Trope lecture on atypical optic neuritis by Dr. Neil Miller. And he explained that we need to stop categorizing optic neuritis as just typical versus atypical. and treating it by its specific etiology. Three major pearls. There's NMO or aquaporin disease, severe, and it's misdiagnosed. If it's misdiagnosed as multiple sclerosis, and a patient is started on interferon or fingolimod, you can actually worsen the visual prognosis. There's MOG disease, and this should be considered in younger patients, pediatric patients, or if you see perineural enhancement, sheath enhancement on MRI. And then there's neuroretinitis, where if you see a macular star, maybe put the steroids down for a second and start to look for whether they have a cat at home. It's infectious. Bartonella is the cause, and this is not MS. And essentially, the bottom line with this is high dose steroids are important to start, but in certain infectious conditions, it might actually worsen the condition. And you might want to have a low threshold for Plex if they aren't responding. The next presentation, the name Dr. Sharif El-Dafrahi lecture on semaglutide, again by Dr. Molan. And essentially, we've all seen headlines suggesting a 7-fold increase of NAION in obese patients on GLP-1s. However, she urged caution that the single cohort study was a bit alarming, and a massive meta-analysis by Silveri covering nearly 300,000 patients found maybe there was not a significant association. She also debunked the decompression theory, where if you have NAION once, the atrophy doesn't really make room, and you can have repeat NAION episodes that can be blinding. So prior atrophy is not protective. The bottom line in this is systemic benefits of these drugs for heart attack and stroke prevention are undeniable, but at this time, the AAO specifically doesn't recommend stopping semaglutide. So next slide, challenges in GCA. So this was by Dr. Tenov, and he broke down differences between arteritic and non-arteritic optic neuropathy. And we all know the symptoms, but essentially in the fundus, if it's hyperemic, maybe it's more likely NAION, but if it's a pallid or chalky white nerve, then maybe you're thinking more GCA until proven otherwise. Biomarkers beyond ESR and CRP, you can look at platelets. There could be a relative thrombocytosis, which is a strong specific marker for GCA. Conversely, the neutrophil to leukocyte ratio greater than 2.5 may point to NAION. Finally, he touched on the future, and AI is now matching experts and distinguishing these two entities based on photos and OCTs alone. In terms of Dr. Rouleau's talk on immune checkpoint inhibitors, he discussed the neurological and ocular toxicities of ICIs, and essentially these drugs are great in being able to help with cancer prognoses, really helping these patients, not with curing cancer, but mitigating as much of the cancer as possible. But there is a 95% general toxicity rate. There was a patient he presented who was on a specific drug and had drug-induced VKH. And the clinical pearl for him was it's important. In the past, we would just stop the drug immediately. But in this case, it's about weighing the benefit of life and death versus the benefit of or the risk of toxicity to the eye and other parts of the body. And finally, from session 5, Orbit Reconstruction, Anatomy is King by Dr. Kahana. He gave us a masterclass on the anophthalmic socket. And the pearl here is stability is just as important, if not more important than mobility. And he challenged a dogma that we suture muscles just to make the eye move. But in reality, attaching muscles is specifically the inferior oblique, in addition to the 4 recti muscles, is crucial for stabilizing the implant and supporting the lower eyelid to prevent that late sunken and ectropion look. He also gave us a concrete rule for sizing, axial length minus 2 millimeters, and this usually gets you a 20 to 22 millimeter sphere, leaving exactly 2.5 to 3.5 milliliters of volume for the ocularis to fit the perfect prosthesis. His closing technique, a posterior mid-tenons closure, and leaving the conch loose and keeping that tarsorrhaphy in for a full month. That's the end of my talk. Thank you very much, and I hope you all have a great day.
Okay, well, thank you, Prem. And I think Mina is up next, if I recall. Good. Thank you, Mina.
Thank you. All right. Hi, everyone. My name is Mina. I'm happy to be here to present Walter Wright Session 3 and the part of Session 5. Let's dive in. Okay. So Dr. Victoria Liang, she presented a topic of lid malpositions, mainly focused on ectropion, entropions, and the trichiasis. She first explained different causes of ectropion and entropion. Then she mainly discussed the importance of knowing the anatomic mechanisms for different types of ectropion and entropion. This is very important because our management is geared towards the fixing the underlying anatomic issue. Then Dr. DeAngelis, he discussed the topic of approach to ptosis and the new developments. He highlighted the importance of knowing ptosis pathology and the management. For congenital ptosis, dysgenesis and dystrophic levator muscles are very important. And intraoperatively, we don't see muscle fibers. It just looks like continuous sheet of fibrotic scar tissue. For acquired ptosis, the main mechanism is levator dehiscence. Then when we are evaluating for the patient, does this patient needs a surgery or not, it's important to ask, is there any visual obstruction? Or for children, it's very important that we have to assess for amblyopia, and the cosmesis is also important as well. In summary, most cases of ptosis are mild and no need intervention. We need to do a thorough history and exam. And the many surgical procedures are available. We have to tailor this for each individual patient's needs and ptosis severity. Frontal suspension still is needed in patients with poor levator function. And then it's very important you have to aware of masquerade syndrome while evaluating ptosis. Then Dr. Daisy Liu, she presented a topic on lumps and the bumps. She highlighted the key features of benign versus malignant eyelid lesions and what to know about them. She emphasized to know, although chalazion is a benign lesion, but when it behaves atypical, such as not resolving in a certain amount of time or becoming recurrent, we have to send for pathology. Then she explained about malignancy red flags, such as last loss, ulceration, bleeding, crusting, and the importance of thorough examination, like knowing risk factors, do a slit lamp exam, lid eversion, and a palpation. And at the end, she explained in detail when do you do referral to oculoplastic, when do you do biopsy, any red flags patient's concern, any suspicion for sebaceous cell carcinoma or melanoma, Merkel cell carcinoma, anything is odd, you need to act on that. Then Dr. Etzoling, he gave us very interesting topic on anophthalmic sockets. He explained the indication, alternatives for eye removal, and then he point out some surgical fine points to surgeons. Most importantly, he emphasized the importance of protect the remaining eye and provide psychological and supportive care to the patients. In summary, evisceration are becoming more commonly performed than enucleation, except for intraocular tumors and scleral melts. The risk of symptomatic ophthalmia is exceedingly low, and symptomatic ophthalmia is treatable. Intraocular melanoma may occasionally be missed even with ultrasound. An unknown intraocular tumor is greater concern than symptomatic ophthalmia with evisceration. In Canada, inert implants were more commonly used than porous on 2020 survey. Pegging requires a porous implant, but pegging is rarely done if ever performed anymore. Porous implant may be more prone to exposure. So instead of exenteration, eye-sparing strategies are increasingly emphasized due to advance in chemotherapy and radiation. And again, we have to protect the remaining eye with polycarbonate glasses. Dr. Ted Wallace, he presented a topic on optimizing the ocular surface as an oculoplastic surgeon. So he first explained the common management of meibomian gland disease. It's one thing we can pay attention that the omega-3 fatty acid, unfortunately, in a larger studies showed failure in improvement of MGD. And again, he highlighted the importance of knowing your oral antibiotic side effect. And that for oral antibiotics, there is no level 1 evidence for visual and keratitis improvement. Then he explained about emerging landscapes. He highlighted one of the very fun procedure he does in his clinic, which is introductal meibomian gland probing, which is technically simple. Patient is comfortable, and it's effective procedure based on his observation. Then he explained the mechanism behind intense light therapy, and then he also mentioned we have to know the complication behind the IPL therapy. And then he touched upon a very nice drop. Actually, it's my first time to learn about this drop in the Walter Wright. It's lotilaner. It helps to eradicate demodex, and it doesn't disrupt the skin normal biology. Then Dr. Azamali, he presented a fantastic talk on corneal neurotization. He explained what is neurotization. It's regeneration of the nerve after being cut. So we can use nerve graft and nerve transfer to either redirect or regrow the axons into degenerated tissue. The nerve graft source are autologous, which comes from cerebral nerve or greater auricularis, or allograft. In summary, it helps to improve ocular surface health and vision and corneal sensation. It works on both congenital and acquired corneal anesthesia. There are many techniques are available, but we don't know which one is the best. And again, it still remains to be worked out how it should be placed in the treatment regimen of neurotrophic keratopathy and how it works with the newer agents such as insulin and the neurogrowth factor. Again, we have to develop better reporting outcomes. In session 5, Dr. Bitas Mali, she presented a topic on updated management of islet tumors, immune check inhibitors for preservation of eye and the function. She first reviewed different types of ICIs. The older ones are anti-CTL4, anti-PD1, and anti-PDL1. A newer generation on the market is anti-LGA3. So we have to know the FDA approved indications in the US. Currently, they're using for advanced melanoma, squamous cell carcinoma, especially for periocular squamous cell carcinoma has highest response rate. It's about 75%. And the Merkel cell carcinoma and the BCC, which is phalodon-sonic Hedgehog inhibitors. Again, we have to wear side effect. It has various systemic reactions, eye-wise, uveitis, ocular muscle enlargement, orbital inflammatory syndrome, and optic neuritis. It usually managed with steroid, and the fatal side effects less than 1%. In summary, it is an important addition for a patient who have conjunctival orbital eyelid carcinoma and the melanoma. Indication may include locally advanced or metastatic disease in the neoadjuvant or adjuvant setting. Immune-related side effects are common, but usually mild and can be mitigated. So in terms of future reactions, we have to develop an investigation for biomarkers that correlates with the response so we can have a better outcome reporting. Thank you. That's my end of my topic.
Okay, well, thank you, Mina. I believe Waleed is next.
Okay, so session 4, next level neuro-ophthalmology skills. So the first talk was Approach to Double Vision by Dr. Prasad. And the most important pearl was to determine if the strabismus is comitant or incomitant. And comitant means equal amount of misalignment in all directions of gaze, just like congenital esotropia and congenital exotropia. Incomitant means an equal amount of the misalignment in all directions of gaze. So the most important causes of neurological incomitant strabismus are 6th nerve palsy, which would cause an esotropia that is worse in the ipsilateral gaze because of lateral rectus weakness. 4th nerve palsy would cause an ipsilateral hypertropia worse in contralateral gaze and ipsilateral head tilt. A 3rd nerve palsy would cause an ipsilateral hypertropia in up gaze that reverses to hypertropia in down gaze because of superior rectus weakness and inferior rectus weakness. Exodeviation that increases in contralateral gaze can be seen in 3rd nerve palsy because of medial rectus weakness. A fourth nerve palsy causes a ipsilateral hypertrophy that is worse in contralateral gaze, and this is because the superior oblique acts as a depressor when the eye is adducted, which is contralateral gaze. A fourth nerve palsy would cause a hypertrophy that is worse in ipsilateral head tilt. And the reason is because, for example, in a right head tilt, you need intorsion of the right eye and extorsion of the left eye to keep the image aligned. So the intorters are the superior rectus and the superior oblique, while the extorters are the inferior oblique and the inferior rectus. And both intorters and extorters, they have different vertical actions. So the superior rectus is an elevator and the superior oblique is a depressor. So the vertical actions, they cancel each other out. However, when you have a fourth nerve palsy, the superior rectus elevation goes unopposed, and this would cause a hypertropia when the eye is intorted, which is basically when the head is ipsilaterally tilted. The afferent pupillary defect in clinical practice by Dr. Miller. So how to test for RAPD? This should be done in a room with dimmer switch, and you should use a bright hand light, and the patient should be looking at distance to eliminate any component of meiosis related to near response. So for a patient with darkly pigmented iris, you can have the patient look up, and this way you can see the pupillary reaction much better. How to check for RAPD in a patient with fixed dilated pupil. Now this can be done by checking for reversed afferent pupillary defect. So you swing the flashing light from the normal pupil to the dilated pupil, and you keep observing the normal pupil. So when you swing the flashlight from the right eye here to the left eye, you observe the right eye pupil, and here the right pupil dilates as you swing the flashing light from right to left eye, indicating the presence of a right afferent pupillary defect. Locations for a relative afferent pupillary defect. RAPD can happen from retinal lesions. However, retinal lesions they have to be severe and obvious, like a dense disciform macular scar, optic nerve diseases, optic tract lesions, and very rarely it can happen with superior colliculus lesions. Unilateral optic neuropathy without a relative afferent pupillary defect. When you encounter this is one of two things. Either the patient has no optic neuropathy, or the patient has a bilateral optic neuropathy. Amblyopia can cause mild RAPD. However, the amblyopia has to be dense with a visual acuity worse than 2400 to cause a mild RAPD. Dense cataracts do not cause RAPD. Management of transient vision loss by Dr. Patel. Transient vision loss basically is sudden temporary loss of vision or loss of a visual field that lasts for seconds to minutes, less than 24 hours by definition, and it is followed by complete recovery of vision. Monocular transient vision loss can be provoked with changes in temperature, which is known as UofT phenomena, which is seen in optic neuritis, or it could be a gaze-evoked amaurosis, which is seen with orbital apex tumors. Monocular transient vision loss can happen in patients over the age of 50, accompanied by jaw claudication and scalp tenderness, and this is GCA. So if you have a patient with an ischemic optic neuropathy preceded by episodes of transient vision loss, this is most likely to be arteritic than non-arteritic ischemic optic neuropathy. Monocular transient vision loss in a young patient with pain. Make sure you rule out painful Horner syndrome caused by carotid dissection. Retinal migraine can cause monocular or binocular painful transient vision loss. There are some ocular causes of monocular transient vision loss, such as intermittent angle closure or intermittent glaucomatous cyclitic crisis or Posner-Schlossman. Transient retinal ischemia can happen with amaurosis fugax or with the retinal arterial vasospasm, which is a diagnosis of exclusion. So make sure if you see a patient with transient retinal ischemia or artery occlusions that you perform urgent stroke workup or refer the patient to the nearest emergency department. Binocular transient vision loss can affect the entire visual field, and this is seen with vertebrobasilar insufficiency. And patients with vertebrobasilar insufficiency may or may not have brainstem signs and symptoms. Papilledema can cause binocular transient vision loss related to postural changes, lasting for a few seconds. Hemianopic binocular transient vision loss can happen with migraine, which causes a kaleidoscopic pattern of transient vision loss, and occipital lobe seizures can cause seconds to minutes of binocular transient vision loss. Approach to facial and eyelid spasms by Dr. Miller. So blepharospasm is basically bilateral symmetric contractions of the orbicularis oculi, and it is of a known etiology. The management is basically Botox or partial or complete myectomy. Meigg syndrome is bilateral symmetric contractions of the orbicularis oculi accompanied by contractions of the mid-face and the lower face muscles that last for seconds or minutes, and the management is Botox or deep brain stimulation. Apraxia of eyelid opening, and it is seen in patients with progressive supranuclear palsy or a Parkinson disease, where patients have difficulty opening their eyelids. It's a bilateral disease, and the management is Botox, and those patients usually require more frequent Botox injections than patients with blepharospasm or frontalis sling. Hemifacial spasm is a unilateral disease affecting the facial muscles of one half of the face, and it may begin as an eyelid myokymia affecting the upper lid, in contrast to the classic benign eyelid myokymia, which is related to sleep deprivation or to excessive caffeine intake, which affects the lower lid. So a hemifacial spasm may start as an eyelid myokymia affecting the upper lid. It can be caused by a vascular compression of the facial nerve, and the management is microvascular decompression of the facial nerve, which is very successful, associated with more than 90% success rate. Differentiating optic neuropathy from glaucoma by Dr. Mullen. The most important pearl that optic neuropathy causes reduced vision, reduced color vision, relative afferent pupillary defect, disc pallor in the presence of a normal cup to disc ratio, and neurological visual field defects include central and secocentral visual field defects, which is seen in toxic and nutritional optic neuropathies. It can cause a temporal a visual field defect respecting the vertical midline, and it could cause altitudinal visual field defect, which is seen in ischemic optic neuropathies and optic disc drusen. Glaucoma does not affect vision until late in the disease process. It does not affect color vision, usually unlikely to cause RAPD, and disc pallor is a late manifestation. Glaucomatous visual field defects includes nasal step and arcuate visual field defects. Moving to case-based neuroophthalmology jeopardy by Dr. Prasad. So Dr. Prasad presented a case of a 54-year-old man with diplopia. So on examination, the patient had limited adduction of the left eye, and on left gaze, the patient had limited left gaze, meaning the patient had limited abduction of the left eye and also limited adduction of the right eye. So the only intact horizontal gaze movement, or the only intact horizontal movement, was abduction of the right eye. So this is called internuclear ophthalmoplegia. And when this is accompanied by facial nerve palsy, so a facial nerve palsy plus internuclear ophthalmoplegia, 1.5 syndrome is known as 8.5 syndrome. So 1.5 syndrome is internuclear ophthalmoplegia and ipsilateral gaze palsy, affecting all horizontal gazes except the contralateral abduction. And if this is accompanied by seventh nerve palsy, this is known as 8.5 syndrome. And it indicates a problem or a lesion at the points. Wernicke encephalopathy, a triad, which causes a triad of ataxia, confusion, ophthalmoplegia. It may cause nystagmus. However, the triad is not always present at the signs are not always present at the same time. It quickly resolves with IV thiamine, and the classic MRI finding is hyperintensity in the dorsal midbrain and hyperintensity in the medial thalami. However, this is only present in less than 60% of the cases. This is another case of a 60-year-old woman who presented with chronic blurred vision in the left eye. She also endorsed having headaches for about 10 years. So on examination, the left eye vision was reduced. Patient had reduced color vision. Patient had relative afferent pupillary defect in the left eye. And the optic disc was a little pale. However, their right eye vision, color vision, they were normal, and the optic disc was swollen in the right eye. So a swollen disc in one eye, and in the other eye, a pale disc with reduced vision, RAPD, reduced color vision. So this is on coronal imaging, the patient had frontal meningioma. So this is called Foster-Kennedy syndrome. And this is caused by usually a frontal meningioma compressing the optic nerve on one side, causing compressive optic neuropathy, optic disc pallor, reduced color vision on one side. And the tumor is so large that it increases the intracranial pressure, causing papilledema. So the optic disc of the other eye would swell, but the optic disc of the ipsilateral side would not swell because it's compressed and the optic nerve fiber layers are atrophied. Now moving to session 5, which is on orbital diseases and malignancies. Update on management of orbital and lacrimal gland malignancies by Dr. Ismaili. So she talked about adenocystic carcinoma. So adenocystic carcinoma is the most common malignant tumor of the lacrimal gland. It can invade bony walls and brain parenchyma. It can cause perineural invasion up to 75 to 100% of the cases, and it can cause bony and lung metastasis in half of the cases. So she described eye-sparing surgery, which is basically performing gross tissue resection followed by adjuvant radiation treatment with or without chemotherapy. So in 70% of the cases at MD Anderson since 2007, Dr. Ismaili's team performed eye-sparing surgery followed by adjuvant radiation treatment, while the remaining 30%, still needed orbital exentration because of the advanced disease at presentation. Local recurrence, interestingly, was not significantly different between the two groups. Now shifting gears to orbital lymphoma, which is the most common primary malignant tumor of the orbit. And more than 90% of the cases of orbital lymphoma is B-cell lymphoma. And the standard treatment for low-grade lymphoma is radiotherapy. However, when you have one of the aggressive subtypes of lymphoma, such as diffuse large B-cell lymphoma or mantle cell lymphoma, then the treatment should include chemotherapy. Dr. Ismaili described ultra low dose radiation treatment for orbital lymphoma. So this is different from the classic low dose radiation treatment, which is about 30 grays of radiation treatment delivered over 2 to 3 weeks. Dr. Ismaili described ultra low dose radiation treatment, which is basically delivering a total of 4 grays of radiation treatment divided into 2 sessions. Each session should deliver 2 grays, and this was associated with almost zero ocular complications, in contrast to the standard low dose radiation treatment, which can be associated with some ocular complications. And the efficacy was comparable between the two groups. Thank you so much.
Okay, thank you, Waleed. And I think you're going to play the
Yes.
pre-recorded remarks from Dr. Ba.
Yes.
So Jenny's up in Timmins right now, so we're playing pre-recorded remarks for her.
Yes.
Hi everyone, my name is Jenny and I'm one of the other PGY5 residents. Today I'll be presenting on the session Combined Neuro and Plastics, focusing on imaging. So first was an approach to orbital imaging. And there are several imaging protocols we can use. In terms of CT orbits, it's good at looking at fat, muscle, lacrimal gland, globe, sinuses, bone cortex, as well as the sella. But some limitations include tumor characterization. For an MRI, it's good at looking at the optic nerve and optic nerve sheath. In particular, if a long segment enhances, it would be characteristic of NMO, glioma, granulomatous processes, infection, leukemia, or lymphoma. And a short segment of enhancement would be more typical in MS and radiation. It's also good at identifying edema as well as necrosis in tumors. However, some limitations include identifying tumor margins, and if a fat saturation is used, there can be susceptibility artifacts as well. In terms of an approach to cranial nerve pathology, we can categorize it by an intracranial or extracranial course. Along the intracranial course, there's the nucleus, and an intraaxial course, which can be involved in infection, inflammation, demyelination, as well as ischemia. Along the cisternal course, this can be affected by meningitis, leptomeningeal diseases, a subarachnoid hemorrhage, extraaxial mass, and aneurysms. And finally, along the skull base course, there can be bony abnormalities. Along the extracranial course, we can look at nerves, which can be affected in primary schwannomas and paragangliomas, as well as during a secondary mass effect. And then in terms of end organs, it can be affected by primary pathology and denervation. Next was neuroimaging for acute neuroophthalmic presentations. So in terms of imaging modalities and findings for common presentations, we went over several common presentations. So first, for a CC fistula, we can get an MRI orbit and brain, as well as a CTA and MRA of the brain. For pituitary apoplexy, we would want to focus on imaging the cellar and paracellar spaces, particularly looking for cystic fluid, rim enhancement, and subacute blood. There are three diseases that can present for inflammatory optic neuritis. So first, for a typical demyelinating disease such as MS, we would look for T2 and flare hyperintense lesions. For NMO, this is typically a longitudinally extensive optic neuritis, often involving over 50% of the nerve and frequently involving the chiasm. Finally, for MOG, anterior optic nerve involvement is typical. In terms of Horner syndrome, we can get a CT or MRA of the neck to evaluate for a carotid dissection and add on an MRI of the neck if the MRA is negative but suspicion is high. Horners can also present with other symptoms such as ataxia, diplopia, and vertigo. And when these additional symptoms exist, an MRI with a stroke protocol should be acquired to look for lateral medullary syndrome, paying particular attention to first-order neurons. Finally, in terms of a fascicular cranial nerve 3 palsy, an MRI of the brain with attention to the posterior fossa should be acquired. Several territories can be involved in GCA. So in a study, 7 cases involving both the anterior and posterior circulation was found, and 3 cases involving only the vertebrobasilar circulation was found. Next, we had a debate on temporal artery biopsy versus temporal artery ultrasound in the diagnosis of GCA. So in terms of advantages of the temporal artery ultrasound, it is non-invasive, it's cost-effective and readily available, more sensitive than a biopsy, allows examination of the entire length of the temporal artery and its branches. The superficial temporal artery on both sides can be assessed, which increases the specificity, and an extended ultrasound protocol increases sensitivity in GCA. We can also reassess temporal arteries for a halo sign if relapse is suspected. On the ultrasound, we would particularly be looking for a temporal artery halo sign, which is a homogeneous hypoechoic arterial wall thickening due to inflammation and edema. A unilateral sign has a sensitivity of 82% and specificity of 91%, which increases to 100% if this sign is seen bilaterally. So given these findings, there is an updated 2023 recommendation from EULAR indicating in patients with a high clinical suspicion of GCA and a positive imaging result, the diagnosis of GCA may be made without an additional test, such as biopsy or further imaging. Some advantages of doing a temporal artery biopsy include that severe complications from a temporal artery biopsy are rare, but are more common and serious for steroids, which may be unnecessarily used long-term if a false positive ultrasound results. So in terms of complications of a temporal artery biopsy, they include brow droop from a facial nerve palsy, hemorrhage, scar, infection, false negative, if there are skip lesions or an inadequate specimen, and rarely scalp necrosis or stroke. Steroid complications include osteoporosis, fractures, avascular necrosis, diabetes, elevated blood pressure, obesity, increased infection risk, as well as skin and mood changes, and in particular for ophthalmology, cataracts, and glaucoma. There's also a risk of false positive ultrasounds. So on a meta-analysis, the false positive rate of an ultrasound was 4 to 19%, with a specificity of 68 to 77% and a specificity of 81 to 96%. However, the specificity of a temporal artery biopsy is 100%. There is also a broad differential for false positive ultrasound halo signs, including PMR, atherosclerosis, non-Hodgkin's lymphoma, osteomyelitis of the skull base, amyloid, GPA, and syphilis. There also exists a difference in cranial versus extracranial GCA, so ophthalmologists primarily see cranial GCA with a higher likelihood of temporal artery involvement, which typically requires immediate steroid coverage. And we can see that 2 days of steroids decreases the ultrasound sensitivity by 10%. However, rheumatologists primarily see extracranial GCA, and from this we can deduce that perhaps the preferred confirmatory test is influenced by the GCA variant, specialty, and region. Lastly, it's possible to stratify GCA risk with an online calculator, leading to the consideration that low-risk patients may be observed or tested via ultrasound, and we can do a temporal artery biopsy for higher risk patients. Next, we looked at interventional radiology and the orbit, particularly at lymphangiomas, CC fistulas, and biopsies. So there exists a great opportunity for collaboration between ophthalmologists and interventional radiologists. Several treatments can be used in sclerotherapy, including STS-3%, doxycycline, bleomycin, and sirolimus, with applications to intraconal or intraorbital lymphatic malformations, periorbital or intraorbital venous malformations, venous lymphatic malformations, carotid cavernous fistula, and bone biopsy. There also exists quite advanced imaging of the visual pathways, particularly in terms of structure-function correlations. So to illustrate this, several patient groups were studied. 3 examples include those with outer retinal disease, such as traumatic maculopathy, and in those patients, visual cortex remains structurally intact, it was found. Next, for retinitis pigmentosa patients, 12 patients were examined with a disease ranging from 7 to over 30 years, asking the question, would long-duration patients exhibit cortical thinning or structural changes in V1? And an analysis found that cross-modal plasticity exists. Lastly, in terms of optic nerve diseases such as NAION, a cortical response on fMRI to light was present. Next, detailed structure-function correlations are resolvable using current techniques, and with these current techniques, little evidence of permanent structural anterograde degeneration was found. However, there is evidence of retrograde degeneration, and this has implications for neurodegenerative diseases such as Alzheimer's and Parkinson's disease, and has applications to amblyopia and strabismus. Lastly, I'll go over some reconstructive techniques used in the oculoplastics realm. So some layers of the eyelid to consider in reconstruction include the anterior and posterior lamella. In the anterior lamella, we have the skin, with best matches coming from the ipsilateral and contralateral eyelid skin, the orbicularis, as well as loose areolar tissue. In the posterior lamella, we have a fibrous layer, including the tarsal plate and conjunctiva. There are many options for reconstruction, ranging from simple to more complex. So going from the simplest technique, there is healing by secondary and primary intention. Then we move on to a skin graft, bioengineered tissue, tissue expansion, local and regional flaps, free tissue transfer, and the most complicated would be a tissue transplantation. Some reconstruction principles to keep in mind are that the vector of contraction should be horizontal with the eyelid, graft on graft should not be placed, and we should replace like with like. For example, skin should match skin and mucosa with mucosa. And finally, in terms of lower eyelid defects, They can be separated into small to moderate defects as well as larger defects. So smaller defects can be closed by direct closure, and then moderate defects, the direct closure can be combined with a lateral cantholysis or a semicircular Tinzel's flap. In terms of larger defects, on the posterior lamella, we have the Hughes tarsoconjunctival flap, and on the anterior lamella, we can advance cheek skin and do a full thickness skin graft. So that was my review of the Walter Wright session. Thank you, everyone.
Okay, well, thank you to all of the residents for taking the time to put together the summary slides from each session. I don't know if Dr. Najawan or Dr. Sundram have any comments or wish to add to what the residents have already shared with us this morning.
First of all, excellent presentation, all of you. I don't have any specific. I think they've done a fairly good review of the polls from most of the talks that were covered in the neuro-ophthalmology lectures. I don't have any specific comments.
Yeah, I want to say from the plastics perspective as well, very well done. Thank you.
Okay, well, thank you guys. Congratulations once again on a wonderful meeting, and to Dr. Slomovic as well, who's already started working on next year's meeting, as we heard earlier today, for cornea and external disease. So congratulations to everyone on a wonderful meeting. This is our last grand rounds of the year, so I do wish everyone a happy and healthy holiday season with their families. I hope everyone gets some time to sit back and enjoy the holiday season. We will see you all in January. Be well.
Thank you.
Happy
Bye.
holidays.
Happy holidays.
Thank you.